10 years ago, people used to say 70% of all the decisions made are based on information that comes from pathology. Now it's about 85 to 90% of the information. I always call myself an accidental scientist.
You're almost like a digitization engine, right? You're turning biology into data. I'm Dominic James, and today I'm joined by Saghar Missaghian-Cully, Managing Director of Northwest London Pathology.
Those measurements and looking at cell structures, AI can really do that and save a lot of time for pathologists so they can do more of the same. Data is already within our system. Utilizing that to do predictive modeling, to target how we can move all of this to that prevention space is going to be quite key. What we can't do is make the assumptions that everybody has access to the technology they need. I think the way laboratory testing is going to evolve in the future is
Welcome to Health in Hyperdrive.
Brilliant. Thank you very much for having me.
So maybe to start off with, it would be good to define a little bit like what is pathology. I have to admit, when I first met you, I heard you were a pathologist. I was thinking maybe forensics, looking at dead bodies, CSI type stuff. I've learned a lot since then, but maybe you can give us a little bit of an overview of what it's all about.
Yeah, absolutely. So I'm not a pathologist, right? So that's the key distinction, I guess, to make. So pathology is usually used as a general term for a bit of a catch-all of lots of different things and different activities. So, and you have lots of different people working within the pathology field. So pathology is comprised of a whole load of different disciplines. So we have, I always say there's lots of ologies within pathology where there are focused sort of scientific activities on very different things. So, you know, I'm sure you've heard about microbiology, virology, you've got histopathology, cytopathology, you know, lots of different things, blood transfusion. There's lots of areas of science where biomedical scientists, and I'm a biomedical scientist by profession, work within the laboratories alongside laboratory assistants, associate practitioners. You have clinical scientists at different grades. So biomedical scientists also come in different grades alongside the pathologists who are medically trained within the various disciplines as well. And together as a workforce, you know, we essentially do all of the diagnostic activity that really underpins, and I would say as a backbone of what healthcare requirements are for actually being able to manage patients, to be able to share really what diagnostic treatments people need to undertake, or what the next steps are for various people that are on a specific pathway. So yes, it's definitely a lot more than what people perceive. I think when we talk about pathology, my own friends always used to think, you know, they used to think about, I don't know if you remember Quincy back in the day, you know, he used to be a medical examiner. So there's elements of that within pathology. People used to talk about CSI Miami and things like that, but it's a lot more of that, and forensics is obviously a branch, or specifically, you know, that's used for a very different requirement. What we do in the laboratories within the NHS is the plethora of all of the tests for all of the various disciplines.
Yeah, and maybe so, you know, in doing a little bit of research for this, I worked in a pharma company. They have pathologists, or they do pathology there, which is really around kind of in the context of medical discovery, right? Yeah. And then you also hear about kind of like digital pathology and also kind of genetics as well. And then there's the clinical pathology, like how, you know,
interlinked is it?
Yeah, how interlinked is it? And in your space, it's specifically the clinical pathology, which is really supporting the health service overall. Is that, have I got that kind of roughly right?
No, absolutely. So again, our function is very much supporting the healthcare. So, you know, the decisions that are made, and again, you can read about all of this in all kinds of different websites. Initially, I think 10 years ago, people used to say 70% of all the decisions that are made are based on information that comes from pathology. Now it's about, you know, 85 to 90% of the information. So we hold a lot of opportunity for people to interact with the services, and that's really by having close relationships with the clinical services that use our pathology services, which again is for a variety of reasons. So, you know, from blood tests to urine analysis, whether it's again looking at cancer diagnostics in histopathology, genetics over the last, you know, few decades has really started to take form in terms of personalized medicine, and really think about identifying very specific things that can go on to cause issues for people later on. And again, personalized medicine and thinking about moving things towards prevention. So, our focus for many, many years has always been diagnostics. And obviously, there are people that work within pathology that will do research and work in academia. They might have different roles where they offer, the day-to-day activity that they have might be in diagnostics, but actually they do research and academia activity as well. But there's a lot that, laboratory medicine, I guess, as a whole, which I prefer as a term to use for us, I think. And it's funny because, my organization is called Northwest London Pathology, but I think we need to change the name that we call ourselves. Pathology doesn't give you the full vision of exactly what it is that is underpinning all of this activity. And so what we use is technology quite a lot. So without technology in our laboratories, we can't do half the stuff that we can achieve. So it helps us enhance the way we work. It helps us speed things up. It helps us focus on utilizing our time better. And so it's evolving all of the time. So our collaboration with people that work within industry is really, really important for redefining what we do. And then there's opportunities to link, when we have opportunities to diagnose people within our hospitals, then there should be a direct link to what then comes from a treatment point of view. So that's where there's potential synergies that can be had with pharmaceutical sort of organizations and what we do within the laboratory, so that we can, especially when we're talking about prevention, there's things that we can do differently, which isn't sort of connected as much as yet.
I really, in having spoken to you, this term laboratory medicine just feels so much clearer in terms of the work that you're doing. And, when you kindly showed me around your labs and explained a little, well, one of your labs, and explained a little bit of, about what everyone's doing. I think that it kind of gave me that clarity that it's people doing the tests really in support of the medical service, kind of overall, giving them the information that they need, turning around, getting the data and, taking the guesswork, I suppose, out of medicine and putting data and precision and kind of science into it, really. So maybe it'd be good to hear a little bit about your background. Like, how did you get into all of this?
Yeah, so I kind of my journey. So I, like many others, actually, I didn't know laboratories existed. I knew labs existed, but I didn't know what happened in laboratories. And actually, the breadth of opportunities wasn't something that was visible to me, even having done an applied human biology degree. My intention was always to go into doing research, so in a very research setting, research laboratory. And it was really through a sort of personal tragedy experience that I stumbled into biomedical science. And it was through my mother was diagnosed with cancer just as I'd finished university. And so I had plenty of time. I was there and available, and I was in hospital with her quite a bit. And the experience that she had was, she started treatment, and sadly that didn't work out for her. And within 6 months she passed away, and she went into hospital and never came out. It was during that time where I had the opportunity to meet lots of different people, all her oncology teams. And one of those oncology consultants, said, well, what are you doing with your time? What are you doing with yourself? So I explained I'd just finished university. And he said, oh, why don't you go and talk to the principal lead of the laboratory at the district general that I was working in. And that's really where I sort of started having any kind of notion of what the laboratory diagnostics sort of arena looks like. And I was introduced to a few people. I then had the opportunity to apply for a trainee position, which is how you started then to become state registered as a biomedical scientist, and then to continue to sort of develop yourself and do additional training and academic sort of qualifications. And so that's really how I started as a trainee. And that's where my journey began. And I ended up in histopathology. And I met my husband actually as another trainee who had started 6 months before in that same hospital. So it's just really interesting. I always call myself an accidental scientist because that's how I sort of stumbled upon the whole world that opened up to me. And actually my path became, through that sort of experience, which is a tragic experience, but actually a lot of positivity. And again, I have my family because I met my husband in my work environment. So it's just really interesting the things work out.
And then from there, as a scientist, you kind of moved into leadership roles, and now you're leading quite a large pathology, in fact, one of the UK's largest pathology operations, right?
Yeah, that's right. Again, the journey of a biomedical scientist and the training requirements are obviously defined and set. So there's an expectation, obviously, that you need to do more training, you become a senior biomedical scientist, and then many people stay within the science and progress and excel within the sort of the scientific field. But I did all of that and then wanted to branch out. I was a bit nosy, I think, always wanting to know. And I think we had a conversation about curiosity.
Is the word.
Yeah, exactly. So I was always curious to know how everything worked. So I wanted to, whenever there was opportunities, I think most people kind of shy away from opportunity, or change is a bit of a sort of a difficult, fearful kind of environment. Whereas I've always enjoyed where there is change, opportunity comes with it, I always think. So whenever there was an opportunity to do something different, I did it. So I did, quality roles, quality and governance is a big part of what we do. Operational management, training and development is something I really enjoyed as well, to be able to sort of help others progress and grow within the field. And then I really enjoyed the whole management side of things. So I branched out and really followed that management path. And through that, general management and other things, ended up eventually being an MD of a different organisation, obviously, before I joined Northwest London Pathology.
And Northwest London is, I mean, it's incredible, the scale of it. I don't know globally how pathology operations kind of work or relate in scale, but it's pretty incredible. I think you told me you did like 60 million tests a year. You serve like 3 million people in London in terms of kind of population.
Yeah.
Staff of about 1,000 people. Like it's a really big operation.
Yeah.
What are kind of maybe the main functions there? Like, how do you kind of break it down, or like what are the main services? Maybe that's the way to look at it.
So, I mean, I guess the uniqueness that we've got. So there's lots of, I think pathology or laboratory diagnostics is delivered in lots of different ways in different countries, right? So the way that we have in this country is that most organizations are NHS organizations. There's lots of, partnerships that some NHS organizations have with other private providers as well, and there's sort of joint ventures with a private entity. The way that we've sort of set up Northwest London Pathology is a completely and wholly NHS joint venture between 3 trusts. So that's Imperial, Chelsea and Hillingdon. And so the coming together or creating that joint venture was really the start of actually how do we reconfigure and what is the operating model that we want to implement for the way that we want to deliver pathology. So the way we chose to do it was really to create a hub and spoke arrangement. So what we did was thought about what are the services that can be fully centralized and put in one location, so that we can really benefit from the opportunities that economies of scale give us, the opportunities to really think about how we configure the operating models that we are going to go forward with. So we created our sort of centralized setup, and that's at Charing Cross Hospital, not to be confused with Charing Cross in London. And so we've got, all of the disciplines or ologies, as I call them, that could be centralized, like microbiology, virology. We've got all of our GP activity that comes in from Northwest London's sort of footprint of over 280 GP surgeries that we serve. All of that comes into our hub, as well as a lot of other sort of centralized activities. We've got our referral center there and lots of special chemistry.
Yeah. And what are the sort of things that would be centralized? So these, I think you told me before, they're like the things that are maybe not so time sensitive. You don't need it within an hour, within a day or a few days. It's kind of ample.
That's exactly it.
That's largely how to think about it.
Yeah, exactly. So there are certain things. So there's what we have is essential services that are retained on each of the hospital sites for the requirements of that service. So where there is an ED or where there is a trauma center or where there is maternity services or renal services, there's sometimes a slightly different requirement that is needed for those tests that need to be turned around in a specific time frame.
So that would be like an hour. I don't know.
So
I
an
need
hour. Yeah. So we do most of our
transfusion. I need something in an hour.
Yeah, blood
or something
transfusion
like that.
has to be on every site. If you've got these EDs and trauma centers and maternity services, you always have to have some blood biochemistry, and you always have to have hematology laboratories. And for some of these tests around hematology, it's usually a 1-hour turnaround time. For chemistry, it's a little bit longer because some of those tests are just naturally take longer
and
for
what's
us.
an example of a chemistry test?
So chemistry, you do. Yeah. So
my daughter's doing chemistry tests at the moment.
Yeah. So there's all kinds of different things that we test for. We might do. Urine albumins, we might do, urea, we might do, I've said albumin already, but, there's lots of tests that we have as a full repertoire for our chemistry tests, which is, HbA1c is for diabetes, for example.
Okay,
So there's a whole host of different. Where hematology really focuses on, it's about full blood counts. You look at your hemoglobin, sorry, you're going to have to edit this one. Hemoglobin levels. You might be looking at some infections, looking at white cells. So it's a much smaller repertoire of activity. Chemistry needs to be treated slightly differently because there are additional steps that need to be done before you can put them on your automated analyzers. And so it's a slightly different repertoire and it takes longer. So those tests stay obviously within that footprint of that essential services laboratory. Things that can be stabilized and moved can be centralized and moved.
Maybe where I get kind of a little bit caught in the science of this. Like, what would be like the disease conditions that you'd be kind of looking at, or
It's
maybe
everything.
even from a patient perspective? Like,
There's all kinds of things.
or what would I be going through as a patient for some of my bloods, or
it could be all kinds of different things, right?
Yeah.
So it could be that. So if you're coming from a GP perspective, so you might have been asked to provide a urine sample because there might be they're thinking about there's some sort of infection that they need to think about what type of antibiotics you need to have. So it could be that. So it might be a UTI for somebody. Someone might have some blood tests done and it shows that there's some abnormalities whereby they need to think about whether somebody's diabetic or not, right? So again, there's tests that are undertaken specifically for that. It might be about your kidney function. So again, there's tests that we would do, both blood work and there's urine work that we would do to define what that could look like. There might be, so those are the ones that might come from less sort of acute sort of setting. Then clearly you've got access from what we get asked to do for ED, for example. So people coming into ED, if there's trauma, there's blood transfusion is the first port of call, but again, there's assessments that need to be done for patients to understand if there's other things that they need to think about. So the bloods that are taken can identify all kinds of different things. Now, what we also then have is people going into hospitals to have biopsies taken, right? So if there's something suspicious, if you've had some images taken, whether you've had MRIs or you've had CT scans or you've had something that is suspicious, where a biopsy is required, which is basically removing a little bit of the appropriate tissue, those go to our histopathology department. So that could be for cancers. So it's trying to eliminate whether somebody's got cancer, or if they have, it's about the staging of that cancer or identifying the specific tumor type so that the appropriate sort of treatments and chemotherapies can be applied to that individual. And then there's obviously all the viruses, right? So
you were telling me about COVID, which is kind of incredible, right?
Yeah. So again, nationally, everyone went into, well, we have to focus on being able to have facilities that can do COVID testing. So all of the NHS laboratories were asked to set up the capability to do that. And, we had to ramp up really quickly to be able to offer thousands of tests on a daily basis on platforms that didn't exist, test kits that didn't exist. So it had to be developed. And it was quite tough, to be able to do that. But what we now have is molecular capabilities for virology and infection sciences that allow us as a routine to test for all kinds of sort of flu, COVID, the respiratory syndromes that come along every winter as well, so that affect, children and adults. So it's become a routine capability now that we have with molecular diagnostics in virology. So I don't know if that kind of answered your query around.
It did. It's so tricky. I mean, I think on the one hand, it's super simple, right? Essentially any kind of bodily fluid or
exactly it.
And anything that kind of comes from my body and goes and gets tested.
Yeah.
You kind of handle that. But then I suppose what's difficult about it is it's so broad ranging. I think it's like, it's everything in medicine, because that's essentially you're providing the fundamental kind of data. Like we're kind of biological creatures, and you're turning our biology into data so that that people can make decisions off the back of it.
Yeah, exactly.
So in some respects, you probably wouldn't view yourself like this, but you're almost like a digitization engine, right? You're turning turning biology into data.
Into data. And I think that's the thing that I always say is that as much as we're a clinical service, we trade information.
Yeah.
And data is that information. And so, that's why being able to link everything that we do back into the information. So we have to have integration for all of our technology, all of the tests that we do. We have to be able to pull that information into a single system that can then move that on to, again, the patient record and to the systems that the hospitals or service users are using. And then there's a lot of value that also sits with that data in that we can do lots of different things, again, as the opportunity arises now while looking at different algorithms and using AI, where there's lots of predictive things that we can do. And, as I'm sure you've heard, there's a big focus, eventually when we get the 10-year plan, the NHS 10-year plan will be published soon, I think. And in that, there is a definite sort of focus on moving towards prevention for a lot of diagnostic activity that we do, but also moving actual diagnostic capabilities more closer to the community. And of course, moving away from analog to digital. So we play a massive role, I think, as laboratory diagnostics and laboratory medicine in all of these things, because we can help influence how the data that we have can be utilized in a much better way to make better decisions and to help thinking about the point of care sort of testing that really needs to be thought about in a different way. Because, we have point of care. Lots of people do point of care testing, but it's about thinking about it in a different way. And how is it accessible? How do we actually make an impact by doing things differently?
Yeah. And maybe you could talk a little bit about some of the technology advances over the past couple of years, because when you showed me around the lab, there's a lot of machinery there. It all looks pretty high tech.
Yeah.
So I think you shared there's a certain amount of like kind of robotics and quite advanced kind of testing machines. What are the sort of the major, say, technology changes in the last, say, couple of years, 3-5 years, something like that? What are the kind of the key advancement areas?
Yeah, so, digitization obviously has been a big change and the use of AI. So for many of our disciplines within pathology, utilizing automated analyzers has been in existence for a long time. So chemistry is a great example of that.
And that's just about faster, more scale.
Yeah, it's scale. And yes, so, you can do all kinds of different assays, so you have a huge repertoire that is able to be performed on these analyzers. And yes, and you can have a sample that is tested for multiple different things rather than having to have different samples for different things because they need to go to different places. So that automation is obviously, and is evolved. And I think some of the things that has happened is that actually you've got much more precise assays that can be used to be tested on these analyzers. And they can be, there's improvements and enhancements in all of those. In some of our disciplines have always been quite a manual discipline. So microbiology was always quite manual up until maybe 10, 15 years ago, where sort of being able to have automated tracks that help, with when we use the agar plates, for example, to grow, because for microbiology, you're trying to grow the bacteria and identify what that bacteria is. And there's lots of other things, so, people have, if there's wounds that are being swabbed, if there is any thought about, if somebody's got MRSA and things like that, all of those things go to microbiology. There's automation that has developed and has helped enhance the way that microbiology works, because it used to be very manual. People used to stand there and had to do all the plating, and then they'd have to grow, obviously, things, and then visually themselves be able to look at things. So there's automation and technology that enables us to do that slightly differently now. There's also the digital functions that we've brought into histopathology. So histopathology is the study of the tissues that are removed from people's bodies, where we need to basically then create a single thin layer of tissue that is then stained, and then under a microscope, a pathologist would review and look at, the tissue structures and look at what's within the cells, and to be able to define the specifics of what it is they're looking at. Which meant lots of slides moving around lots of different places, and there'd be piles of slides, on pathologists' desks as all of their cases that they're going through and reviewing. And then if you're doing multidisciplinary team meetings where you're coming together with surgeons and the wider sort of multidisciplinary team, you'd have to then go and show your slides under a microscope and share that. Digitization and using digital pathology is really changing that. And that essentially means that when we create that slide, an image is taken from that slide, which then can digitally be shared anywhere and can be reviewed anywhere. So consultants no longer need to wait for a slide to be delivered to them or they go and pick it up. They can log into a portal where they can see the full cases. They can look at multiple slides at the same time rather than having to look at one microscope slide at a time. And the other enhancement that the AI gives us is to be able to utilize it for where you need to measure things, right? So for some things you need to measure distances. For example, if there's a margin, you're trying to see if there's the cells that you're looking at, are they clear from a margin that might need to inform what surgeons might need to do next for this patient. Those measurements and looking at cell structures, that AI can really do that and save a lot of time for pathology so that they can just do more of the same.
This is so fascinating. There's a lot of press at the moment, certainly in the AI space, of AI detection of diseases based on looking at slides. Does that kind of fall within your remit, or that normally falls within, say, the oncologist's remit?
No, we do that. So there's imaging. So for imaging services, there's AI technology that can be utilized in that area, where again, I think it helps radiologists to be able to identify areas that they should be focusing on more easily. From a histopathology point of view, it's about the AI being able to identify perhaps where there isn't anything suspicious to look at as an assistive tool, if you like. So not to make the decision, but to say, actually, I haven't found anything suspicious here, but there's these areas where you might want to look closely. And then the pathologist can then go to that particular area and see if that is the case. And that can save a lot of time. And another area where that is really helpful is when you're doing in hematology, when you're looking at digital morphology, which is where you have something suspicious that you need to, again, make slides. Again, the traditional way of doing this is somebody sitting there looking down the microscope and counting cells. The AI can do that in seconds, and it can group the different types of cells and tell you, this is what I've seen. So it really enhances the way that we can use it. I think in this country, most of the sort of labs that I've come across, we're looking at as AI utilization in labs more as an assistive tool, not as the AI is doing the diagnosing. So it's assisting the pathologists and the scientists to do better.
I guess I'm thinking of it maybe even slightly differently. Like I'm rolling a bit with this theme of your capability essentially turning something that's biological or analog into digital, and then what that enables is like it enables you to do more things in terms of, I don't know, AI analysis or any type of analysis. AI is reliant on data, and if you're at the center of bridging the human body and data and providing effectively that information base, you could see almost like an explosion in the need or the opportunity for the services that you provide, right? Because the constraint is no longer an individual being able to analyze a slide. The constraint is now the amount of data that I have on a patient, because the machine can do a lot of the analysis really quickly.
Yes.
So do you have that kind of view of the world, that or are you even feeling that at the moment, that there's a lot more pressure for data, or it's not quite there yet?
I think everyone's talking about data being the key thing. And I think a lot of the fixation that we've had within my realm, if you like, is more around, how do we store all this information? Where do we keep all this data? How much data should we be keeping, right? So there's an element of that about the storage of information and then how that can be utilized. But it is something that people are talking about, because it's actually quite a rich source of information that can be used for all kinds of things, right? Clinical decision support, looking at how we then develop, if we use that information and feed it into, AI to be able to do better things with, whether it's in population health management, if we're looking at inequalities and iniquities in health and access for people to the appropriate sort of signposting of people for healthcare purposes. So I think I would say we're not quite there yet, right? So, and I think there's still a fair amount of fear and trepidation, more around the governance that we're going to sit on and utilize. I think a lot of people are still waiting to see what happens and what shape this is going to take. But there is absolutely, I think, our future is utilizing these opportunities with the data that we've got to keep evolving AI to be able to help us, because we do know the challenges that we've got, in terms of workforce are not going to go away. We know that demand for services is going up and up and up. And there is always, the opportunity to do things better and do things more quickly for patients. So I think embracing the use of that data and being able to develop the right algorithms to help our people become more efficient in what they do, I think is really essential. But I don't think we're feeling the pressure of the need for that as much, perhaps in some of the diagnostic sort of disciplines that we have within lab.
I probably jumped the gun a little bit. Like we were talking a little bit about today and recent things, and I'm probably projecting a little bit further forward than that. But maybe I can kind of recap a little bit, and you can correct me if I'm off track with this. But today, a lot of the technology is around. It's definitely around efficiency. It's around speed. It's around data management. So getting the results to people quicker, the distribution of these things, simplifying processes so I don't have to take kind of multiple samples, and maybe a little bit of kind of consistency, and then provide or augmenting a little bit the expertise through some of these tools. Is that kind of largely the recent advancements?
I would say so. Yeah, I think so. I think that's exactly it. I think is that, and there's a lot of excitement, I think, for the opportunities that this is going to give us in terms of how we can operate and how we model our future sort of configurations of services. And I think that it allows us to maybe think about becoming a bit more connected with the world outside of laboratory diagnostics, because for a long time we were kind of behind these closed doors doing our own thing. But actually the utilization of these technologies and the data, which is essentially patient information that sits within the systems, whether it's in the hospital or within the LIMS systems of pathology departments, that I think that connection with clinical services and us playing our part, and then what happens afterwards, I think it's going to be, again, the next iteration of how we will evolve and the role that we'll play.
Could we talk maybe a little bit about prevention and population health? You touched on it a little bit in the context of maybe what the future looks like. And then I suppose, the testing around COVID is really around
it's testing en masse, isn't it?
It may be less about well, there was some prevention stuff as well. It's such a distant memory.
Preventing the spread, wasn't it?
Preventing the spread. Is there are there kind of major initiatives that are happening in terms of prevention at the moment that you're involved in, or not so much at the moment?
So I think that there is lots of work going on. There's a lot of organizations, a lot of trusts around the country are looking at population health. And, there are people who are working within this space, whether it's through the life science sort of groups that have been set up, looking at really accessibility to healthcare and then actually the inequities that exist. And, there's been a lot of studies, I'm sure you've come across them, where people have, plotted people's life expectancies, going maybe 2 or 3 miles down the road from a particular hospital. And there's vast differences of, 7 or 8 years. And so what that boils down to is actually, is it about education? Is it about access? And what is it that we need to do to make sure that we start thinking about prevention? And so a lot of organizations are doing a lot around reaching communities, making things more accessible, thinking about why people maybe don't come and access healthcare.
But from kind of the organization that you run at the moment, is it more
so we're looking at point of care. So point of care, I think, is where we can really add value in this space. And again, utilizing the data that we've got there are algorithms that we can utilize, which are specific to maybe sort of groups of patients, where they call it clinical decision support. There's certain things and criteria that maybe you can look at by running certain algorithms on the data that you've got that say, actually, if this patient's got this and this, maybe they need to be followed up for various reasons. And so that way you are catching people before they have developed something that is a diagnosis, you're actually preventing it from happening. So what we're trying to do is to think about what are the types of tests that we can offer. And you can start quite simply with things like diabetes and obesity, which again go on to create a lot of other issues that is not only unhelpful for the patient, but actually also costs a lot for maintenance and the wider health economy. Looking after our lungs, so lung function for people, the kidney functions. So and also prevention of the extra utilization of antibiotics, right? Antimicrobial resistance is something that the whole world should be concerned about right now. And we do need to do what we need to do to ensure that actually the right prescriptions are given to people by being able to diagnose them quickly and before a course of antibiotics is started for someone that perhaps wasn't the right one, for example. The conversations that we're having is to try and talk to people that supply pathology services, technologies to us, to think about what are the types of offerings that we want to put. And I hate the word pilot because I think we do too much piloting and not enough doing, right, within our work environment. But sometimes you have to prove a concept and to show that actually this really adds value. And I think that is when we start bringing together the clinical service, the diagnostic services within pathology, with all the data people and the industry around, okay, you've got this technology, how can we best use this? And agree a repertoire of tests that we can do in a different way. Not everything needs to come to a big lab like ours. Some things can be done in a different setting, so that community setting where there's better access potentially for people who will come forward and be followed up. Are we fully in that space yet? No, we're not, but I think it's definitely somewhere where we are trying to establish it and to try and navigate really what is going to be of value. Because I think fundamentally what we offer as laboratory medicine or diagnostic services, we should be adding value from the data that we've got for people to make the right decisions. And that shouldn't always be after something has become a major disease that's trying to be diagnosed or treated.
So is that, I mean, when I look at, as I have done, like the major trends in healthcare, you've touched on quite a lot of them. Prevention is a really big one. Health at home or health out of the hospital.
Yeah.
Precision medicine is another one. Kind of augmentation of clinical processes to kind of make the clinics more efficient is another one. Social determinants of health or helping people access the healthcare system. Those are actually the major trends. And I think you've touched on all of them.
Yeah.
Is that, are they kind of how you would see the sort of the big opportunities? Say if we were to project forward in the next, say, 5 to 10 years, is that maybe what the future of pathology looks like or laboratory diagnostics looks like?
I think so. I think, there's a lot of people are really interested in their own health now, right? So there's a term that somebody's coined, they call it consumer activation in healthcare. And I think that's already happened. People want to know information about themselves. We all have phones, we all have all these wearables. We have, I'm not wearing mine, but, they have Apple Watches or Fitbits or whatever. There's a lot of data that we like to collect about ourselves. So I think utilization of wearables and being able to assess what you need to do in that prevention space, I think is an area that, again, can really enhance what we're trying to achieve around prevention. There's a lot around sort of bespoke diagnostics as well. So, so it's targeted therapies are basically utilization of our genetic material, right? So that molecular testing, that genetic testing, which can really define potential markers that can signpost that actually this could be something that this individual can develop, or equally, if they have already developed something, to be able to target specifically what can help them get better and get treated. So I think those are the areas that I think are going to be quite significant for our immediate future. Combine that with the utilization of the AI to be able to sort of maybe do some predictive analysis. And, again, we know from population health management, where people live, where populations are that have already accessed healthcare. And that data is already sitting within our system. So utilizing that and being able to do some predictive modeling to be able to target how we can move all of this to that prevention space is going to be quite key. And again, a lot of hospitals already have virtual wards, for example, right? So where somebody, rather than staying in a hospital and being looked after, if they're able to do so, they are at home, they might have some wearable devices, they have contact with the hospital who might be monitoring certain things and then acting on it as necessary rather than them having to come in for patient appointments where they don't necessarily need to do the travel and the inconvenience. So I think taking responsibility for our own health, being able to sort of allow people to maybe not be in hospital and then using that data to actually do the prevention stuff, I think is going to be quite exciting.
Do you see the sparks are flying a little bit, right? Do you see this might be a little bit science fiction, but do you see a world, say 5-10 years time where everyone is, I don't know, having a routine sort of blood test at home that either they have a machine for or they're sending in, that's kind of providing a little bit of the data for prevention? Or
I think it could happen. I mean, there was a...
Or it could be blood test or urine test or whatever, but something that's, you're not waiting for as you said, waiting for something to happen. You're being a lot more proactive about it.
Because, I mean, if you think about, people can already go and buy, blood pressure monitors that they have themselves, right? So, or you have devices that you wear that monitors your insulin levels and gives you your insulin based on what your requirements are. Whether everyone's going to be able to do certain types of testing, I think there's technologies that are being developed, because I think for blood tests, the tricky element has been how much blood do you need to get to be able to do the right level of testing. And sometimes things have come on the market or companies have come and gone because they promised certain things that didn't deliver, right? So but yeah, I think that is the way that things will go, is that there will be, for certain conditions or certain monitoring purposes, there will be devices that people can utilize for themselves so that they can then make those judgments and decisions as to, actually, now I need to go and see somebody, or no, I'm okay. Whether it's 5 years away, I don't know, because I think obviously these things need to be, they need to go through the regulatory requirements. We do like to, take our time with some of those, rightly so, but I think there are devices that people are already using, right? And I think, we underestimate the capabilities of people to look after themselves. We just need to be able to help people understand what the devices do, how to best use them. And then I think with devices at home, what we do need to be careful of is usually there's some sort of, maintenance that you have to do for these things. So I guess the tricky thing will be to understand, how do we make sure that people are replacing them if they need to replace these things, or that there is some sort of maintenance that is done by some entity that needs to exist? Because what you don't want to do is create sort of like the Wild West of everyone's doing their own testing, but actually everything needs to be retested because nobody believes the result.
Yeah, and that's a little bit where we are at the moment, right? There's CGMs you mentioned, the wearables. When I hear from kind of specialists and physicians, they're like, my patients are coming in with, their wearable data, and like, I can't make any sense. It's not that I can't make any sense of it, but I don't
know what to trust, or
or it's not been done in a I can't look at 10 people's like Apple Watch data kind of separately as a printout. It needs to be kind of integrated in the system, and then there needs to be a strategy, and it needs to be sort of deliberate about it. So there's definitely that component, and it will be even more so with some of these kind of biological tests. But what you're talking about, though, is quite a shift, isn't it, in philosophy from the way kind of a test comes into your lab is through a GP or through a hospital. But actually it's something more proactive. It's happening through kind of community. I mean, that happened a little bit in COVID. What about, also during COVID, there were all sorts of kind of analysis of the sewage system for diseases and things like that. Are those sorts of things that you get involved in, or is that?
No, we don't do it's like environmental testing. So again, it's an area that, diagnostic laboratories could
So they were testing, like, say, I don't know, like the urine in the sewage system to see what people have had, and whether people have had COVID or whatever.
Yeah, so we don't do a huge amount of that. I mean, our sort of repertoire of tests really focuses on what's coming from the people themselves. But I mean, we have done there are laboratories that do environmental testing and, testing water, for example, for systems. We do drugs of abuse and There's monitoring for compliance for people taking their medicine, right? So the
Okay.
drugs that there's the tests like that we can do, and we do. But yeah, there's a whole host of other things that, we can do. I mean, veterinary medicine is another area where the same stuff that we do for humans can also be done for animals. But, we try and obviously focus on keeping those completely separate, and different laboratory requirements and the needs are slightly different. But yeah, it's all diagnostic testing, blood tests, or a urine test. It's much of a muchness.
So definitely a kind of a future where we're looking at kind of population health a lot more, and the role of laboratory medicine in that. Do you see you talked a little bit about kind of home testing. Do you see a world where you would be the provider of kind of home testing, and home testing maybe devices, or maybe it's whether it's a device or a mechanism, right?
Yeah,
Either
I think,
people take the test and send it to you, or whether they do it in their
I
home or
think
community.
that kind of happens a lot already, right? So there's, providers that have sprung up again post-COVID, where you could do postal tests and various other things. There's companies that already do some tests. It comes down to what repertoire of tests can you do that with, right? So what you've got to do is you've got to be able to sort of make sure that what you are collecting is enough for you to be able to do what you need to do with it. So yeah, I think, there's certain things that can be done by doing it through like a postal arrangement, whereby somebody takes a sample, then they send it into our laboratories. Some of that, for bowel cancer screening, for example, that is already something that is sent home. People will take the sample, they send it into a laboratory, and we do the testing. So there's and there's lots of discussions now about people doing testing for HPV at home, and so people are capable of these things, right? So and organization like ours can facilitate that. And we could be the laboratory that sits behind all of these types of things. It doesn't have to be some other entity that is created specifically for that. But you have to be able to sort of balance that, in an NHS environment. You have to think about the costs, because that adds an additional sort of requirement into what you need to think about from a financial point of view. But again, if it helps you make those improvements, and you've got later on savings within the health economy, it makes absolute sense to think about some of those areas of prevention where you can send the tests to a patient, they do self-sampling, and that already happens. So it's kind of real, but we just need to do more of it.
Projection of that a little bit.
Yeah.
So we've talked a lot about, in the context of the future, we've talked about prevention, the role of getting tests before you have symptoms. We've talked about on-scale population health. We've talked about the kind of efficiency that you get from AI and digitization. We also talked about wearables. In a world where not everyone has access to technology, or isn't necessarily comfortable with technology, how do you think about those people in that future? Are they going to get left behind?
I think that's the key question, isn't it? Because I think what we can't do is make the assumptions that everybody has access to the technology that they need to be able to, whether it's monitoring devices or being able to access the information that we need. And I think that's where, again, within the NHS construct, in a sense, there is a lot of work that a lot of trusts have done to really work with communities to get a sense of, some of these iniquities that exist, so that assumptions are made about what people can and can't do. And it doesn't mean that actually it's not possible. It's about understanding what is missing. And so it's I think engaging with communities, there has to be an element of actually going to people rather than expecting people to already know what they need and come and ask for it. So championing within communities, somebody that liaises and engages with health services is really, really essential. And I think, there's lots of groups and lots of charities also that work within the various spaces for different types of areas of focus, for diabetes, or whether it's for like Alzheimer's. What we've got to do is really engage, I think, in those processes and identify where there is a place to actually do something slightly different. So some of it might be educational pieces that need to be done. Simple things like translation services, right? So when people are wanting to access certain things, or if there's instructions to follow for things that they're being given to utilize, we shouldn't assume that everyone can read English, because in some communities that's not the first language that people speak. So I think there's a role that we play in making sure that we understand that people that use our services or access them through, the health system are not necessarily, the same. So there is variation in that.
I think that you kind of hit on a couple of really quite interesting points. So some of it is that technology, I mean, it's kind of meeting people where they are. That's part of it. There's kind of more the community thing when you think about social capability being a key advancement in technology, that kind of opens up quite a few kind of possibilities. If we can bring kind of communities or advocacy groups or different kind of parties together through the technology to get access where maybe there isn't access at the moment, that's quite an uplifting proposition.
Yeah.
There's also, I guess one of the things I also think about with this is the fact that technology frees up capacity. What that enables you to do is redirect some of the more kind of people intense type work to those that need it more.
Yeah.
So that's also another benefit. And then the translation one, I think, is a really interesting one because it's definitely, there's language, which is a big thing, but it's also people's kind of comprehension, their medical understanding, how they absorb information.
Yeah.
I have friends whose first language is English and they don't always understand what a doctor is asking them or a medical professional. And the AI tools or some of the kind of translation technologies can put things in terms that people understand and create kind of much more kind of effective communications as well.
Yeah.
So there's tons of opportunity there.
There is. And I think, one of the things that, again, we do and we should do a lot more of is again, engaging with people within their own communities is about, if there's an opportunity to go and share, if there's a stand that you can have at an event where you can talk to people about pathology or diagnostic testing or what their healthcare sort of arrangements are and how they can access things, that's important. We do a lot of stuff with schools as well, so that, again, within our sort of space, within our environment, within our sort of geography, where we are trying to, it's almost like a, public engagement piece, I think, that needs to go with some of this. When we think about public engagement, I think people think sort of big bang stuff and, big adverts on TV that talk about certain sort of things that people should be concerned about or things that they should do differently. But there's lots of things that you can do in local communities as well, and engaging with different groups that, whether they're the elderly folk or whether it's actually the young ones who are all vaping now and don't have a clue the damage that they're doing for themselves. So there's lots of stuff that we can do there because, we have the evidence to be able to share, actually, if you don't do this, this is the better outcome.
Yeah, so you have both the evidence from the data and then you also have the precision in terms of targeting,
Exactly.
who needs it and who doesn't.
Yeah.
Let's maybe if we kind of lift this up a little bit to the future that you or that we've discussed around prevention, about better access, about monitoring at home. What are the kind of the tailwinds here? What's kind of pushing you towards that direction? And then maybe what are some of the headwinds? What would you need to happen in order for us to reach that reality as quickly as possible?
Yeah, I think there is definitely a need to think about how, we need to break down a bit more of the silos, I think, that exist, right? So, as much as I think we've broken down quite a lot of the silos within healthcare, what we are not doing is pulling in from all of the various sort of disciplines that can help each other. So I think the role of laboratory information is going to be quite key in being able to break some of that down so that we can utilize that better. I think there's still a bit of fear and trepidation around utilization of data and how we use it and how we invest in the people that are going to be working within our environment. So I think some of the key challenges that we will have is that actually there is more of an opportunity for us to think about data scientists working within our fields a lot more, people that are, statisticians that don't necessarily sit within the laboratory diagnostics setup. And I think that's more of those we need to focus on so that we can actually utilize the information and make some of these changes. Some of the limitations are, again, there's so many devices out there, right, as well, and lots of organizations that also develop technologies for the utilization of wearables and other things like this. That, again, there's an element and utilization of co-creation, I think, here that could be really helpful in that, if we were to talk to people that are developing devices, for example, where we can talk about some of the limitations and why, if, like you were saying, for that example of a friend who has lots of patients coming to them and say, well, I don't know what all this information is and it needs to be in one place. So I think that's the type of thing that we need to get right, is it the right thing? Are we testing the right thing? Is it giving the right information in the right context? And does it mean something in the wider context? Because if someone goes and has a follow-up, can that information be available? So I think those are the things that we need to put right. And again, they're not difficult things to overcome. It's just getting the right people in the same sort of conversation around how do we make this pathway, if you like, much simpler so that we've got the right things in place so that we can get the right information to make those decisions for people.
It's really around, it's interesting that you've said that, because the constraints aren't really technical, are they? They're people constraints, and it's about collaboration.
Yeah.
Health is a team sport, and people need to
For
collaborate, and
Yeah.
that's what's going to guide us to this future.
Yeah.
Saghar, thank you so much. This has been an incredible conversation.
Thank
I
you.
really appreciate it. So
No, it's
thank
been
you.
great. Thanks very much, Tom.